Good evening and welcome to today's webinar. I'm Danae Aber. I'm the Healthcare Innovation Supervisor with Well Ahead Louisiana. Thanks so much for joining us today. As a reminder, your lines are muted to prevent background noise, but please feel free to enter questions into the Q&A box at any time during the presentation. We will probably have a little break somewhere in between to take any questions, and then we'll certainly have time at the end for questions as well. Today is the 9th in our Telehealth in Practice webinar series with Dr. Ted Hudspeth. And today we're talking about disparities in care and telemedicine's potential to address some of these disparities. The slides and recording will be available on our website, along with the recordings of all the previous sessions you can see listed there. And they are on our website at walpen.org/telehealth. And we're also working on these 4 pre-recorded sessions, which should be on the website in the next month or so. As a reminder, this series is funded in part by the Texas Telehealth Resource Center, which is a HRSA-funded program at Texas Tech designed to provide technical assistance and resources to telehealth programs in Louisiana and Texas. And Well Ahead is partnered with TextLaw to serve as the support representative for Louisiana providers. And TextLaw is part of the National Consortium of Telehealth Resource Centers. And with that, I will hand it off to Dr. Hudspeth.
Well, hello, everyone, and thank you for joining us for our 9th installment of Telemedicine in Your Practice. I'm hopeful that everything that we're bringing to you is helping you think about and plan for telemedicine to be delivered to your patients from within your practice itself. We usually like to start off by asking if anyone's had any questions from the previous installments that we've had. So we'll move along, but if you have any during this presentation, please put those in the Q&A box, and Danae will alert me to them, and we'll try and get them answered. Danae, did you have any from your from emails or anything like that during the last week?
I don't have anything right now.
All right, good deal, good deal. Okay, we'll start off today. Of all the forms of inequality, injustice in healthcare is the most shocking and inhuman because it is often results in physical death. That's a quote by Martin Luther King. And those words rang true when I saw those words. They're very powerful, stand by themselves, and truly, I think in today's disparity discussion in our nation, healthcare is really where it makes a huge, huge impact. And I want to go through some of the things that we obviously know about our country and our own locations. You guys, I really felt like this whole presentation should have really been a tabletop discussion or virtual discussion to learn what everyone is seeing in their clinics, because you guys are living in areas, often in the rural areas. That's what we know often has the greatest disparities, and people who live those every day. And you are in the trenches trying to care for folks who often don't have the means to be able to get the things that you recommend that they get to help them. So that must be very difficult for you to see that patient after patient. So my heart goes out to you, and I am hopefully going to present some thoughts here of trying to implement some telemedicine practices to help some of those who maybe can't get to you or be cared for in other ways. So let's move along here and just go through an overview of what I'm going to present to you. I'm going to first look at just health equity and disparity. And there's something that I learned about called the Area Deprivation Index. This is an incredible tool that allows you to be able to drill down to zip codes and see what the disparities are. So you guys live in a lot of these areas, so you know what it is. My thought in presenting this to you was to give you a tool that you can use to show others what you're dealing with in your own practices. I'll talk about some of the Louisiana disparity highlights, and then we'll talk about causes of rural health disparities and specifically social determinants of health, which we are using in our own practice very aggressively to try and help everyone on the team who's caring for a patient understand, what obstacles that patient is coming to us with, so that we can adjust the ways that we help manage their care and help them. Including that, I will talk about some cellular and broadband statistics. So moving more towards, the telemedicine end of this, and how does that fit with all of this? And then some opportunities for equity in health through this method. And then I'll talk about a couple of personal recommendations. So starting off with equity versus disparity. Equity is when people have the inopportunity to attain their full health potential, and no one is disadvantaged from achieving this potential because of their social position or other social determined circumstances. And it is also the absence of systematic disparities in health between and within social groups that have different levels of underlying social advantages or disadvantages. So it's basically differences in society. And this area of deprivation index that I mentioned a minute ago, it was developed by Amy Kind at the University of Wisconsin. And it basically ranks neighborhoods by socioeconomic disadvantages in a particular region. It looks at the basic things that we think of with social determinants of health, income, education, employment, housing equality, and things like that. And it summates all of those risks into stratification between regions. And basically it goes down, like I said, to zip codes. This is used on multiple levels, both government, business, et cetera, to be able to determine policies and various things that need to be addressed in various areas. So this is a really strong tool that is used by so many people to help our disadvantaged brethren. So I'm going to show you that right here. When you bring it up, it comes up into your map, and I'm going to actually click on it and bring up a live version of that online. So let me bring this up. I'm going to clue in here on Louisiana. And let's see, you see how it's various colors. I'll see if I can drag this over here. Well, it doesn't have that there. Yeah, the various colors. Blue is actually really good as far as, not very disadvantaged. So I'll click over here. You can see it gives a rating of 2 over in St. Tammany Parish. But if we go to an area maybe over here near Alexandria, that's a 10 over in Rapides Parish. So from here, you can actually drill down to the address. You can actually get as detailed as that, okay? So when you're looking at if you're attracting patients from various areas, you can see what all of this is. And I even included the area deprivation for Texas, because we may have some Texas friends on this presentation. But the pertinence of this is this is used a lot in studies, okay? So if studies or if they're wanting to do something on a particular area and look at a particular disease, they do go to this deprivation index to find out their population that they're studying. So some very important things that are obvious, I'm sure, to every one of you on this video, is that the area of deprivation index has been shown to predict readmission rates at an urban teaching hospital. They show widening inequalities in US mortality. Now, this was a pretty long study looking at 1969 to 1998. In this time frame, it was continuing to worsen, and we all know the gap is worsening over time. That's not anything new to those of you who are in the rural areas. And this is more recent, the effect of the area deprivation index on COVID in Louisiana. They showed a 40% higher risk of COVID for those folks who were in areas with a higher deprivation index. So that's probably pretty standard. You would understand that. And looking at various diseases like diabetes itself. So I use this page really for references for you guys to kind of go to if you're interested in looking at some of these studies. But they obviously showed there's worse obesity in these particular regions. Glycemic control is worse in those areas. There's disparity with people actually getting admitted with diabetes. There's problems with people dying with their diabetic ketoacidosis, greater if you live from that area or come from that area than otherwise. Hypertension has the same thing. Looking at broad swaths of folks with hypertension, the controls are worse. Lung cancer, both incidents, obviously, of smoking, and then incidence of lung cancer, it all goes the same, and actually deaths from lung cancers are greater from those areas. Breast cancer, between screening and actual cancer itself and deaths from cancer is higher. Cardiovascular disease, shown a positive thing. Strokes, same thing. So all of these things, we've talked a little bit, probably on just about every single presentation, we've been talking about value metrics. And man, it is very tough if you're living in an area and you're being expected to bring value, so to speak, to your patient population as far as an insurer is concerned. It's very hard when you are working pretty much exclusively with folks who have these challenges. It's probably almost seems insurmountable, I'm sure, at times. So, in preparing for this presentation, going through all these statistics, it's amazing to me. And like I said, I wish this was a roundtable discussion because I would love to hear some of your stories of what you're having to deal with. But let's move along. I'll go to some of our specific Louisiana disparities. So in Louisiana, there's actually triple the poverty rate of Blacks versus whites, but there's a greater uninsured rate. There's double the infant mortality rate, double the diabetes, greater heart disease and cancer deaths, increased breast cancer, double the cervical cancer deaths, and more Blacks, both men and women, don't have a physician or someone who they consider their healthcare provider. This comes from actually the Louisiana State database on this. Also, COVID vaccinations have been less in that community. So there's great differences in this. And there's another reference that you might utilize to be able to share with folks the inequities that you see in your own practice. And that's the Louisiana State Health Assessment Dashboard. This actually allows you to kind of drill down on some of the information about Louisiana residents specifically. And it shows where health inequities exist, both with health outcomes and, again, those determinants of health that we discussed. So some of the top lessons that you can learn from this dashboard when you look at it is that rural communities don't have the same access to health as urban communities. We all know that. I read one area where there's about 30 specialists per 100,000 residents in the rural areas versus like 250 in the urban areas, per 100,000 residents. So it's no wonder that people can't access care if they, live so far from that kind of specialty care. Black, Indigenous, and people of color in communities don't have the same access to health services as white communities, and differences in behaviors and exposures and access to healthy choices. We all hear about the folks living in the food deserts. They just don't have access to some of the fresh foods that could be healthier and things like that. So I made a side-by-side picture of the area deprivation index versus quote unquote rural classification. It's pretty similar where there's a rural classification. There's a deprivation index that's a little redder than other areas. So you guys know, because many of you live in this areas and work in this area. And I then took this one. This is actually all of the rural healthcare facilities in Louisiana. And thank God there's a preponderance of you guys in these areas helping these folks. who live this disparity every day. Texas, I found one too for them. So the causes of rural health disparities, I think probably the biggest is going to be the social determinants of health between education, access, and quality, healthcare access and quality, neighborhoods specifically, and then social connections and economic instability. All of these are various things that add up to people not having an opportunity. It comes down to really the opportunity to move ahead and be in a healthy state. The second thing is access to care, being able to access health providers, both primary care and specialty driven folks. It's not as easy to get to those folks. And it all comes down a lot of times to actually their transportation issues. And we'll discuss that in a minute. I'm going to move along to barriers of care in the rural areas itself. We've talked about hospitals or lack of hospitals in those areas. Rural Americans have about 15 to 20% of the US population. Per 100,000, there are about 30 specialists, there's my number, in rural communities compared to 263 specialists in urban areas. And 54% of rural communities do not have a hospital with OB services. Thankfully, the CAHs and FQHCs are positioned right where some of the biggest needs are at this time. So I really like this map too, although there's not as many as we probably need at this point to be able to service folks better. And coming back to transportation, I think this is where, many rural area folks just can't get to the doctor to begin with. And that is why I think telemedicine itself is such a huge opportunity for us if we can manage to make that easier for them and have services for folks to be able to basically get the care in their home. If that's an opportunity, that would be phenomenal. Obviously, there are a lot of things to overcome that you will have to work on. Not everyone has a cell phone, not everyone has broadband. So what do they have? Do they have a family member that might have one of those? And trying to, I guess, delineate how patients could be engaged through a telemedicine visit, I think would be one angle to go in to kind of start your own project and engage them and help them if they have some disparities to begin with. Average trips to a doctor or dental service is about 9 miles longer for rural folks, and there's not much public transportation to get them there. And despite there being a lot of facilities, there's still probably not enough to service folks as good as they need. So this is what I really want to focus on: cellular and broadband statistics, because when you look at the data on this, broadband and internet disparities are really, they're first of all based on income. If you look at the folks who, let's see, it was over $50,000 of household income, 93.5% of those folks do have broadband, okay? But folks who average 25,000 or lower, only about 64% of them have broadband. So then if you also look at households located in metropolitan areas, 86% of those folks have it. And in rural areas, only 78.1% have it. This is actually a little bit bigger slide of what I just said on those differences between urban and rural. As far as Medicaid patients, they have about a 79.2% access to broadband versus those who do not have Medicaid in the home, 86.9% actually have broadband. So that's coming down to about 3/4 of your population if you're in a rural area, is what it looked like to me. If you have a disabled person in the home, it's only about 76% of people actually have broadband versus 88% of folks who don't have a disabled person in the home. Of course, there are state variations. Those of us in Louisiana and Texas are at the bottom. We all know that. And specifically in Louisiana, it averages around 75%. And this particular slide is a link where you can go in and drill down to your own city. Up in here, I'm not going to link out to this right now, but you can go later and see that. You can see actually what your access is in your community. So that may give you some benefit if you're trying to develop a telemedicine program to see what your potential may be in that. And then Texas is similar. 74.6% of folks in Texas have broadband. And in this particular picture, the blue is better with higher speed internet and the green is worse. This is just a picture of Texas where they're showing the minimum amount of broadband that you need for telemedicine visits is a 25 meg download. And you kind of see the breakout on that. And this is the Texas broadband interactive map, where it's actually one you can actually drill down to the community and see what that community has also. So this, to me, these next two slides are very important for this presentation because I think it gives a little bit of an angle and a thought for you in a practice as to, well, how do I do this if there's so much disparity? Because what I'm going to present to you is somewhat exciting to me and maybe to you also. First of all, most folks prefer doing a telemedicine visit on their cell phone, not a computer. And so that really is interesting. It's kind of like, you know, how do people like to talk to their friends? If they're going to do a FaceTime call, they're going to do it on their cell phone as opposed to a computer or a laptop. And so because of that, that's where this next thing really drives home to me. Prior to the pandemic, most patients were required to have access to broadband and high-speed internet in order to participate in a telemedicine visit. But the technologies really spread fast. You know, most programs that you go through to have a telemedicine program will actually do that through any device, not just a computer like prior to the pandemic. Today, everything will pretty much go through a cell phone. And what is interesting to me about this slide is that when you look at the disparities of who has a cell phone and doesn't, the differences are pretty negligible between races. So that means that if you're going to develop a telemedicine program and you're worried about disparities, you really need to focus on doing it where a patient can do it through a cell phone. They, number one, like that better. Number two, they're probably all going to have an equal access to that. And if they don't, you know, there's got to be one family member who could. And so that's where I was talking a little bit earlier about trying to think about how would you delineate or document somewhere in your records how that patient would like to be connected to via a telemedicine visit. Is it that their niece is the one who has to get them on the visit, etc.? So that could be a way for you to start incorporating this and have, I guess, a verified way to go ahead and do it and set it up easily in the future. But that will take some planning on your part in all your documentation and your workflows, okay? But I think this is a real opportunity as we move forward to help people who have some disparity, and transportation and access is their biggest problem. So looking at some of the opportunities for gaining some equity in health, that's what I kind of wanted to go through. And here, there's a few exciting things that are coming up. First of all, for broadband access itself, there are a couple of programs. One is the Lifeline Support for Affordable Communications. This is actually an FCC program which gives low-income subscribers a discount on their monthly service. So their telephone service, broadband internet service, or bundled voice broadband packages they actually help folks be able to gain access. And in Louisiana right now, there are 667,000 people who are eligible for this program, and only 277,000 people are actually participating. So that's a huge number of people that could be participating with a cell phone. I have some friends who are actually looking at trying to have their social workers in their departments get patients signed up for these programs so that they can participate in that kind of care. And it's not just telemedicine visits. When you start looking at all of the other services in a health system that can be given to patients to help them with their care and become healthier, a lot of those things can be done through telemedicine. It's not just us doing a visit. So getting them the access is a critical point here. And the other thing that really excites me is Governor John Bell Edwards has an initiative to get broadband for everyone in Louisiana. And this is really moving along at a pretty fast pace right now. So they have a commission. It's called the Bell Commission. Interesting that is, John Bell and it's BEL, but that stands for Broadband for Everyone in Louisiana. They are facilitating the private sector, public sector, and other broadband stakeholders to come to the table and improve the adoption and availability of broadband everywhere in Louisiana. So they actually have a goal of having broadband everywhere by 2029. I know in my own parish of Tangipahoa Parish, we recently, and this was about 2 or 3 weeks ago, we received a grant, multi-million-dollar grant to make an entire circle around our entire parish with fiber. I mean, this is going to be huge. And, me in medicine and trying to do telemedicine, this is so exciting because I know that people are going to get greater access to that. And it's going to take time, obviously, but it's in the works and moving forward. So I kind of reviewed all that with you already. Now, these next set of slides, these are meant more to be references and just for me to tiptoe through the topics on these. And it's probably stuff that we've talked about before. But when you start looking at various strategies to be able to treat various diseases, I kind of wanted to go through those and have you think about various ways you can do it. There's the live synchronous video conferencing. That's what we've been talking about for all these past 9 presentations. How do you implement it? How do you make it and everything? And that's where you talk face-to-face through a video conference with a patient. And then there are store and forward video conferencing where basically a patient is sending health information into the provider to make decisions. There's a concept called e-visits where on an e-visit, the patient presents with all of their symptoms. You already have all of their history. You're making a clinical decision and then providing the patient with that care. So e-visits are going to be a big thing as time moves on. And you're not actually talking face-to-face with the patient. You guys, I'm sure, are doing e-visits all the time right now. When you get a phone note and you manage a patient's complaint with a phone note, that's basically an e-visit, but it came through the phone, okay? When you start getting into where a patient has a portal and an access to your clinic, then a lot of times the messages come directly from the patient through a message, and that can be managed as an e-visit. There's the concept of remote patient monitoring. This is basically just any device you can think of that monitors patients' health statistics. For instance, a congestive heart failure patient who has a scale, and that sends in a message every day as to what that patient's weight is. Then you have a team of people who are monitoring that, and they know that patient's target weight. And when it gets over that, they engage with the patient. And this is all done in an attempt to be able to reduce readmission rates if you're tracking that. So that's what that type of telemedicine is, so to speak. mHealth refers to some of the health-related apps that are coming out, and a lot of these are things that use artificial intelligence to kind of remind the patient to do this, that, or the other when certain apps are finding certain information about your body as it's tracking you over time. A lot of that kind of sounds kind of science fiction, but it's being used today. It's basically reminding people to maybe take their medicines, etc. So that's the mHealth part. And of course, the audio only, probably most of you have done audio only visits in your practice with the pandemic. This chronic disease care via telemedicine, we kind of mentioned on this, following the weights of congestive heart failure patients, et cetera, but doing medication reminders and adherence reminders and looking at clinical outcomes like blood pressures, glucoses, and all that kind of stuff. That's being used by a lot of folks. And there are great studies that show it. And this is a link to that particular study. This is where I'm going to tiptoe through all the topics. These are some partner tools, the CDC partner tools and resources for folks who are using telemedicine, especially with respect to disparities and trying to ameliorate those. This is different ways for you to be able to manage diabetes in telemedicine. These are studies on that and different tools that you can look at, and I think would be very helpful if you're going to do that. This is a tool to help you with hypertension care in telemedicine. And then this is tobacco cessation. And there's some great studies showing effectiveness and good outcomes with tobacco cessation in telemedicine. And then on this particular slide, it's a very busy one, but I just wanted to use it to highlight that there are so many areas of medicine that can help with these virtual health application models. So we talked about synchronous care up here. This is basically you doing your telemedicine visit. We're looking at physician to physician communication. So let me talk about that. There's another concept that's being used called e-consults. And this is one thing that I really think would be great for you in the rural communities. So the e-consult is a concept where you have the ability to consult a specialist. So for instance, say I'm seeing a patient, and actually I did one recently. I had a patient that had an abnormality that was found on a scan, and it was a mass, and I was concerned that it was a tumor. It was actually an MRI initially, and they said that I needed to get a CAT scan. I got the CAT scan. The liver mass was actually a large cyst. So I was like, great, this isn't a cancer, but a large cyst, I don't really know how to manage that exactly. So I put in an e-consult. I basically summarized my notes and was able to send that entire electronic chart to a specialist who then looked at the chart, looked at my concerns and my question, the main question that I had. And then I was sent back information on how to effectively manage that. Now, what that did for me, number one, it allowed me to keep my patient in my clinic. Number two, it allowed my patient to, number one, not have to travel, okay? I just thought this would be such a huge opportunity for folks in the rural areas. They didn't have to travel, go and meet a new doctor, et cetera, because, many times that probably just won't happen to begin with, okay? And then you're kind of held with the bag, how do you treat it? How do you manage it? So I was able to find out the recommendations on this and the follow-up that I should do. And all of that happened within a day. Again, that helped me and my patient on access and timing of access. How many times do you try to refer someone into a specialist in a distant city and it takes weeks to months to see them? Well, in this e-consult world, I am seeing that is like, it's quick. So that is a model that I really think you ought to look at to maybe help service your patients if you have an opportunity to do that over time. Chronic disease management, we actually had a presentation on that a few presentations ago on how do you take care of folks' chronic medical problems over time. And then virtual social work. There's telehealth care. So that's basically improving disease monitoring of like intensive care units, psychiatry units, stroke units, and things like that. So it's basically an in-hospital type thing. We talked about the remote patient monitoring, care management process. This is where patients' understanding and engagement of their treatment plans can be helped. And we actually did a presentation on some of that chronic care management, on some of that care management process earlier. And then patient adherence, getting them to take their medicine and monitoring those types of things is able to be done through telemedicine. And then, of course, care coordination to improve the payers and the providers' relationships. And a lot of this is actually done by insurers today. They're reaching out to patients and trying to help them with their care because they're responsible for them financially. This particular slide was a CMS Medicare Disparities tool that I thought would be helpful to you if you're looking at trying to kind of help folks who have disparities through a telemedicine program. And so opportunities and recommendations. We all know that there's a huge need to serve the underprivileged in the rural areas. You guys are living that every single day. And my thought there is where there's a need, there is an opportunity. And the opportunity here is that you are uniquely located in the areas where these people have the greatest needs. And these ethnic disparities, in smartphone access in the rural areas is negligible. Their ability to have an access to a cell phone, the disparities in that is negligible. So through that, I feel that you would be able to help people get onto a telemedicine visit more readily without a disparity in your mind. And there are programs in place to dramatically advance internet access in the rural areas by 2029. And that's a long time away. But right now, someone in the family often will have an access to a cell phone and can probably get most folks online if that is something that they need due to transportation issues or other barriers. So my final recommendations here is if you're planning a telemedicine service via smartphone-enabled platform now, to grow with the current and the future needs and abilities. I should have added abilities in there because people will be able to get online more readily as time moves on. And I recommend that all healthcare workers seek and develop innovations to close these gaps in all disparities and service those patients in need via telemedicine. I do think that you guys, if you have an innovative mind and spirit, that some of the things that have been presented over these past presentations, and hopefully a few in the future, will help you if you choose to do so. So we have all of the resources that we've tried to collect over time. These are at the back of all of our presentations, these references that should help you along. And of course, you can always contact us at wellahead@la.gov. And the next link to walpen.org/telehealth is where you can see all of the other presentations that we have given thus far. So I'll open it up for any questions if anyone has any.
We do actually have a question in the Q&A. In the e-consult example that you gave a few minutes ago, how is the consulting physician compensated?
I don't recall the exact RVU for that, but first of all, it's not just them that's paid. The referring provider is also paid. And I do know that's a 0.7 RVU if you are in an RVU world. I do not know the dollar figure on that at this moment. I actually have some folks doing some research for me on the actual payouts for those, but I don't have the actual dollar figures. But I do know that both of those are compensated, and that's why it's such a big deal. You actually, when you go in and do these, you have to document the time that you took to prepare all of that information to be sent to the specialist for them to review. And then they have a code that they drop. I do know how that is calculated. There's one code if the specialist only sends a written document back to the referring provider. Then there are 3 other codes that are used if the specialist actually calls and speaks with the referring physician and sends documentation back to the provider. And that's based on time. I think it's for the first 10 minutes, it's one code, 10 to 20 minutes, it's another, and above 20, I think is a third code, if I'm not mistaken. But so those are the different codes that are used. So that's an excellent question. I really feel this is going to innovate the ability for rural folks to be able to see a specialist in the not too distant future. That is going to be a big deal. And I think the e-visit concept is going to be an equally big deal, because I think about your own practice and how many times you treat things through the phone. It's all the time. I know you probably answered 20 to 30 messages a day that you're managing something. You're making an evaluation and a management decision, and many of those could be done through an e-visit. What we've talked about prior to this presentation has been some of those should be converted to a telemedicine visit. We've talked about that. There are some things you need more information. You need some clinical clues when you examine the patient through a telemedicine visit. And that was another presentation. We went through all of the things that you can do to examine a patient, a full exam of the patient. So again, go back and look at all those. That was a great question. I appreciate that. Are there any others that you can think of?
I don't see any in the Q&A now, but I do want to mention you were talking about the current plan to expand broadband access, and the governor's office has a committee, and they're doing a lot of work on that. They actually just recently announced that they are working on a mapping project. And so there's a link, and I think the governor put out a Facebook post and probably a tweet with the link in it, and it's a speed test. You go in and you put in your home address, and then you click a button. It's very fast. It takes about a minute, and it'll actually test how fast your internet speed is where you are. And so they're trying to get as many people as possible to take that speed test, so they can map the speeds of broadband across the state, so that they can really focus efforts where the broadband is slowest, and increase the access across the state. So be on the lookout for information about that. We're actually going to be including some of that in upcoming newsletters as well, with the link on how to take that speed test.
Yeah, and even one of the references that I had for you earlier in this presentation with Louisiana on it, and the broadband speeds and that kind of stuff. Well, all of those are put out by the broadband providers, okay? And so that's their advertised rate. I think what the governor is interested in is, what is your actual response? What is your actual number at your address where you're being pinged from whenever you send that request? Because that's what's advertised is probably not what you're getting. That's not the quality that you're getting. And they're interested in that. Another thing I think they're interested in is providing competition in those rural areas, and providing ways to be able to do that, because without competition, people can charge whatever they want and provide not as much service as maybe is needed. And I think the governor is trying to ameliorate that also.
Yes, and we've seen the FCC map will sometimes indicate that there's coverage in an area, but really that could just mean that there's one internet provider that their advertised speeds are, technically fast enough, but that doesn't account for how much that costs.
Yeah.
If that's a really an accessible internet service. And there's actually if you have a patient who has trouble paying, for internet service that is available to them, another thing that we're about to send out some communication about is a credit to get a $50 discount per month per household on internet service. That's a recent, I think it's a HRSA program. So that if you have patients who have trouble paying for internet, that's a really great service that's available to them now.
There's a question about, with respect to rural health clinics, there was a grant wherein rural health clinics were going to be helped with funding to get to a better speed. Any news on that? I don't have that. Do you, Danae?
Without knowing what grant you're referring to, I don't know. Because with COVID has brought a lot of attention to this issue. And so there's money all over the place. And so the mapping thing is kind of part of that. The credit for families to get a discount is part of that. There's a ton of COVID funding for various things. So without knowing what that grant is or who was actually issuing that money, I apologize, Meta, I can't help you. If you remember what that is, then I can look into that specific grant for you and try to figure out where that might be, if that's happening or not. But I honestly don't know at this point, and I apologize for that.
I breezed over this slide, but I went back to it because it's pertinent to this question. I took this directly from the governor's commission's page, okay? Because they kind of have some idea of what they want in different business sectors to be able to do in the rural areas when they roll this out. And specific to healthcare is this: they would establish a baseline data of health centers utilizing telehealth and monitoring strategies by July 1st, 2020. So they've hit that with whatever center they were making. And their goal was to have broadband, as broadband's deployed, ensure 100% of health centers can offer telehealth with monitoring services to their service territory. And then they were going to establish a regional goal to increase the number of clients accessing the service. That means, the patients. Promote available healthy living screening and wellness trainings offered by health centers and organizations. And that would be to be able to be delivered through telehealth, okay? And then explore federal and state opportunities for healthcare providers to submit for reimbursements for telehealth services and for patients who need broadband to use the telehealth services. And again, I think that's an expansion on the program that is already offered for the phones, but they're wanting to do a similar thing for the broadband access to folks who need it. Broadband is like water and electricity these days. You have to have it to get just about everything that you need, these days. So kudos to the governor for really investing a lot of energy in this and trying to move everyone forward, because obviously we all do need that for our practices as patients are going to start moving more towards telehealth services to be able to gain their health care. So any other questions?
All right, let's see. With respect to the earlier question, recompensation to the specialists, could you provide more information that a fee-for-service practice could charge where they're providing such detailed information on an RHC patient via e-consult?
Well, if you're going to do fee-for-service, you can do whatever you want. You can charge whatever kind of fee you want if they're paying cash. Basically, I don't think there's any governance on that. It is, I will say, it is a like a 25 modifier on top of, like, if you have a regular visit, it needs to be, first of all, done as part of a visit, as far as I understand it currently. But you have your regular visit, but then you have this additional thing because you're doing additional work to compile all of this and communicate with the specialist, and then later interpret what they gave and then implement what they gave. Okay. It's for the patient, these are generally cheaper than going to the specialist. Their copays to see the specialist is probably going to be less, but they do incur an expense on that end. So I think that answers it. In a fee-for-service world, you do what you want and what the market can bear. Any other specifics on that or questions on that? That I said, and you can figure out in your own world, what does a 0.7 RVU look like to you? I don't know, but if you've ever worked in an RVU world, you can kind of gauge it from there. Because I do know that's what most folks in an RVU world charge for that.
Give her a second, see if she has any follow-up questions. Give her a minute to type.
You know, I would think that what's going to happen is in the not too distant future, you will probably see places that have large specialty bases will probably start offering that to clinics to see if they can help their patients and to, you know, outreach to them.
All right, so she says she has no follow-up questions.
Okay, great. Thank you for that, though.
So we do have a couple other people online, so we'll just give them just a second in case they would like to type in any questions before we wrap up, because we do have a few minutes. Any other thoughts, comments, Dr. Hudspeth, while we're just giving everyone a minute to type questions?
Well, I will share, you know, this gave me an opportunity to go and talk to all of my clinic staff. I wanted to find out if, you know, if they had ever personally experienced disparities in care. They work in healthcare, and I wanted to know, did they ever have any issues with that? And it was really eye-opening for me to see how many people had experienced some of that, and saddening to me. But I'm glad that this is a topic of discussion that everyone can get out in the open. It needs to be. And because, like Martin Luther King said, you know, the end result of disparities in healthcare results in death. And that's a major statement. And we as a society should not be doing that. We should be caring for those who are most vulnerable. I think one of the pertinent things that it'll probably ring a big bell with you, but one of the stories that I was told by one of my own coworkers was of an aunt who was very sick and never could see a specialist because of her particular insurance that she had was not well accepted. And, you know, that created a big disparity and ultimately a bad outcome for her. And it was because of access to care and specialty care. So again, that really rang a bell with me with this e-consult concept. And the fact that it's there, we need to flesh that out as a community and, you know, as a state. When I say community, as a state, we need to be doing more of that to be able to get the people what they need, you know, management. Now, obviously, some things can't be treated. Sometimes the specialist has to see them, just like you have to lay hands on some of your telemedicine patients. But when your wheels start turning, think of all the things that you probably could manage that you just aren't quite comfortable with right now. You know, if you're presented with something you're just not quite comfortable, but if you were given some good direction and good support, you know, you could do it, you know. So I just think it's a very exciting future for that particular way of helping people.
I would like to take that opportunity to kind of springboard off of that and put a plug in for the ECHO project. I don't know if who's familiar with that project, but it kind of builds on that model of primary care providers can do so much more, you know, and if we really let them practice at the top of their license with just a little bit of input from a specialist. And so the ECHO model connects primary care providers and specialists together to do case presentations and have discussions and get some feedback. And it's a really, really exciting model because it's the whole point is demonopolization of knowledge. And it's just specialists who just want to share. And it's like, you can take care of this patient where they are. They don't need to drive all the way out here to see me for everything. Sometimes they will, you know, at some point, some patient is going to need to go see the specialist, but you know, if we can take care of them for longer, closer to home, then, you know, you get better outcomes in the long run. And so we have a diabetes ECHO project that's working on that specifically for diabetes. And we're so excited to have such a great team of specialists, and they even learn from each other, which is really cool to see the internal medicine physician talking to the cardiologist who's talking to the endo, and they're asking each other for help on their own patients and their own cases. And so it's a really great model that is expanding across the world. So we're excited to see that happening.
One of my colleagues is a hepatologist, and she's involved in an echo project for that. And she told me, she said, there's no reason why I should be the one, only one around here treating hepatitis C. She said almost everyone can be managed. And that's why she's doing the echo project. Like you said, demonopolization of information. It's a great thing, because there aren't enough hepatologists in our state to care for all of the people with hepatitis C right now, so.
And it actually started with hepatitis C. Because the provider that started the echo model, he had the same experience where he's like, I'm the only one within 400 miles who's treating this, but a primary care provider can do this treatment. This is curable, and there's no reason for patients to die because they can't come see me because I'm 400 miles away. And so he went out and started teaching providers and built the model from there. So that's really awesome. I'm glad to hear that she's done that. So, all right, well, we will go ahead and wrap up for today. Thank you so much for joining us. As a reminder, the slides and the recording will be on our website at walpin.org/telehealth. There's also a form on the bottom of that page where you can submit questions if some come up after the session. Our next webinar will be at 5:30 p.m. on Thursday, May 20th, and we're going to talk about telemedicine hardware. So we're really excited to be able to talk about all the cool tools and bells and whistles. After you exit the session, you should get a survey question in your internet browser about topics for future education. So if you have any telehealth related topics that you want to see in some future webinars, please enter that in there and let us know. And as always, please feel free to reach out to us at any time with questions. And thanks, and have a great night.